She has contributed scientific content at the World Glaucoma Congress, the Asia Pacific Academy of Ophthalmology, European Glaucoma Congress, and many more international as well as national level programs. She is also council member of the SARC and member of the Women in Ophthalmology Working Committee of the SARC. So Dr. Dilruwani, this is indeed a great pleasure for us to have you with us this evening. And I, on behalf of Glaucoma Society of India, I extend a very warm welcome to you and look forward to hearing to you. Thank you so much for joining us. Over to you for your talk.
Thank you, Dr. Pandey, for the kind introduction. Can you see my slides?
Yes, we can see.
Right. So at the outset, I like to thank the Glaucoma Society of India for giving me this opportunity. Last time I visited India was in 2018 to Bangalore for a glaucoma meeting, and there's a photograph taken at that meeting. And last time I met Professor Nazrul Islam was in 2019, if you can remember. That was when we hosted the Asia Pacific Glaucoma Society Symposium in Sri Lanka. So unfortunately, circumstances have changed drastically due to the pandemic, and we are not able to meet in person. So we'll move on to the topic proper now. Today I'm going to discuss the role of the anterior segment OCT in glaucoma, which I feel is underutilized as an image modality. As you know, evaluation of the drainage angle is critical for accurate diagnosis of glaucoma and appropriate therapeutic intervention. There is also a wide spectrum of anatomical variation in the drainage angle in normal and affected eyes. So in this talk, I'll be discussing the potential benefits and limitations of the anterior segment OCT when compared with conventional gonioscopy and other imaging modalities. So it is not only the angle structures that are responsible for angle closure glaucoma. Forces at different anatomic levels in the eye may be responsible for the pathogenesis of angle closure, such as iris in pupillary block, ciliary body in phacoiris, lens in phacomorphic glaucoma, and factors posterior to the iris, like in malignant glaucoma. As you know, gonioscopy remains the reference standard for assessing anterior chamber angle. It permits dynamic visualization of the entire angle quadrant. It allows indentation, differentiating appositional and synechial angle closure. But it has drawbacks. A proper training is required to perform a gonioscopy, and it's a contact technique which can be cumbersome to the patient. As it's a subjective technique, it can be affected by various factors such as patient's cooperation, examiner's skill, the type of lens used, and etc. Furthermore, it does not provide quantitative evaluation of the angle, and it is also limited in visualizing structures posterior to the angle. On the other hand, imaging of the anterior segment allows us qualitative as well as quantitative analysis of the angle. Furthermore, quantitative analysis can be used to monitor change or progression over time. So these are the current options available to image the anterior chamber angle. Ultrasound biomicroscopy, or the UBM, is a high-frequency ultrasound machine. However, UBM is relatively more uncomfortable, requires a superimposition and a highly skilled operator in order to obtain good quality images. It requires contact with the eye using either a cup with a coupling medium or a probe, which can lead to corneal abrasions or potential infections. Although UBM is useful technology capable of providing both qualitative and quantitative analysis, its major advantage lies in its ability to visualize the structures posterior to the iris, to detect various causes of secondary angle closure such as plateau iris, ciliary effusions, or iridociliary masses. Shim-flu photography is a pentacam, which uses a rotating Shim-flu camera to provide a three-dimensional image of the anterior segment of the eye. Although this non-contact device allows rapid image acquisition and provides measurements of the anterior chamber depth and volume, corneal thickness and lens thickness, it does not provide detailed information of the angle recess because of the light scattering. Therefore, it has limited application in documenting angle closure. iCam is another way to image the anterior chamber angle. The iCam was originally designed to obtain wide-field photographs of the retina in pediatric cases. However, the modified optical technique can be used to assess the anterior chamber angle. Good agreement between the iCam and the conventional gonioscopy has been documented. Anterior segment OCT is a technique we frequently use to assess the chamber angle. AS OCT is a high-resolution cross-sectional image modality first described in 1994 using the same wavelength of light as a retinal OCT, namely 830 nanometers. This wavelength was suboptimal for imaging the angle due to limited penetration through scattering tissues like sclera. Imaging of the anterior segment with a longer wavelength of 1310 nanometers was developed later. AS OCT uses the principle of low-coherence interferometry instead of ultrasound to produce high-resolution cross-sectional images of the anterior segment of the eye. AS OCT technique measures the delay and the intensity of the light reflected from the tissue structure being analyzed and compares it with the light reflected by a reference mirror. Signal intensity depends on the optical properties of the tissue. The device uses these signals to construct a cross-sectional image of the structure being analyzed. So when we compare the AS OCT with the UBM, UBM has the unique advantage of enabling structures posterior to the to visualize structures posterior to the iris, but it has a limited scan width of 5 by 5 millimeters. So AS OCT can be used as an adjunct to gonioscopy as well as a substitute when gonioscopy is not feasible due to corneal pathology like in corneal scars or following corneal grafts or lack of patient cooperation. And also it is extremely useful as a patient education tool, especially when laser peripheral iridotomy is being recommended. So being a non-contact and can be performed under dark conditions, it allows angle assessment during physiological mydriasis. So in these two images, you can see how the angle parameters differ in physiological mydriasis. In the first image, the angle is narrow as the pupil is dilated, whereas in the second image, angle opens up when the pupil is constricted. As it gives the full anterior chamber view, we are able to assess the corneal thickness, anterior chamber depth, lens vault, and angle-to-angle distance, which are important in guiding therapeutic distance in angle closure. An important landmark to identify when interpreting AS OCT images is the scleral spur. This is visible as an inward projection of the sclera at the junction between the inner scleral and the corneal curvatures. Scleral spur location is reported to be successful in approximately 72% of the images obtained by the AS OCT. Schlemm's canal and Schwalbe's line can also be visible. Anterior segment OCT plays an important role, not only in identifying the angle structures qualitatively, but also in providing quantitative measurements using special software. So OCT goniometry is the new term given for these objective measurement tools obtained by the AS OCT to quantify the angle opening. The commonly used quantitative parameters are angle opening distance in millimeters, that is the perpendicular distance between a point 500 micrometers, that is AOD 500, or 750 micrometers, that is AOD 750, anterior to the scleral spur and the opposing iris. Trabecular space area is T of 500 or 715 square millimeters, is a trapezoidal area bounded by the AOD 500 or 750, the anterior iris surface, the inner corneoscleral wall, and the perpendicular distance between the scleral spur and the opposing iris. Angle recess area in square millimeters is the triangular area bounded by the AOD 500 or 750, the anterior iris surface, and the inner corneoscleral wall. So wide angle-to-angle scan of 15.5 millimeters or even with newer scans more allows us dual angle assessments in angle closure glaucoma. So based on the iris profile and the position of the lens with respect to the anterior segment structures, mechanisms of angle closure such as pupillary block and the anterior lens wall can be discerned. The study by Tingong demonstrated that angle closure patients had a mean lens wall of 901 micrometers compared to 316 micrometers for controls. Also, they demonstrated that an increased lens wall increases the risk of angle closure by 48 times compared to a smaller lens wall. A study presented in 2014 in AAO described the AS OCT parameters during an acute primary angle closure attack. They demonstrated that shallow anterior chamber depth and smaller eye curve were the two main parameters associated with primary angle closure. So there are new insights from imaging to assess the risk of development of primary angle closure. The risk factors include the iris thickness and the area, the anterior chamber depth and the anterior chamber width, and the anterior chamber area and the lens wall. So risk is higher with a steeper lens wall and a shorter anterior chamber width. These are gonioscopic images and the AS OCT images pre and post laser iridotomy. You can see in this patient how the angle has opened up nicely after the laser iridotomy. So there's another patient who has had a patent iridotomy, but still the angle is closed. So what is the diagnosis? If you look carefully at the quantitative data of the AS OCT, you can see that the patient has a high lens wall. So to relieve the crowding of the angle, this patient needs to undergo a lens removal. So one should always perform gonioscopy or AS OCT, even after laser iridotomy, as it might not open the angle completely if the underlying mechanism of angle closure is different. These are AS OCT images of two different patients following trabeculectomies referred to us with very high IOP. First patient is a pseudophakic and the other patient is a phakic patient. So what can you see here? So what is the diagnosis? Both patients have flat anterior chambers. In a phakic patient, the entire anterior chamber area is filled with the crystalline lens, and there's a significant corneal scarring. So flat anterior chamber with high IOP is malignant glaucoma. So the phakic patient underwent an anterior vitrectomy, lens removal, and a PKP at different stages. This is the AS OCT of the patient following surgery, and you can see how the anterior chamber has deepened and the angle has opened. This is AS OCT of a patient presented with high IOP. We can see a deep anterior chamber and a closed angle. So this is a UVM of the same patient. So what can you see here? This anterior rotation of the ciliary body. So this is plateau iris syndrome. AS OCT can be used to assess the iris contour in pigment dispersion syndrome. In this condition, the pigment liberation is actually due to secondary to rubbing between the iris pigment epithelium and the lens zonules due to increased irido-lenticular contact. So first image is of pre-blinking in an eye with pigment dispersion syndrome. And the second image is of post-blinking, which shows increased iris concavity, deeper anterior chamber, and a widely open angle from increased irido-lenticular contact as a result of blinking. So this is a society of a patient following blunt trauma resulting in hyphema, angle recession, and a choroidal haemorrhage. AS OCT is a very useful tool in patients following trauma to assess the amount of damage. Also, AS OCT can be used to evaluate filtering blebs and glaucoma drainage devices in the post-operative period. Clinically, blebs can be described as diffuse, cystic, encapsulated, or flat. However, these descriptions are subjective, and there may be cases in which clinical appearance does not correlate with the bleb function. Therefore, visualizing the anterior segment and the intra-bleb morphology with OCT will enhance the understanding of the surgical outcome. So what can you see here? This is a patient following trauma. Is AS OCT of an aphakic patient with a corneal opacity. AS OCT is a very useful tool to assess the anterior segment pathology in the presence of corneal opacities following trauma. So finally, I would like to discuss two clinical cases. This is a 64-year-old lady with uncontrolled IOP who was referred to us. So what can you see here? There's a patent iridotomy. In addition, you can see some laser marks on the iris. She has undergone laser iridoplasty, but these marks are due to laser iridoplasty, but they are a little too central to be effective. So these AS OCT of the same patient. What can you see here? There's iris concavity due to the previous iridoplasty, but the angle is still closed. So we've performed a combined phacotrab. These are the pre and post-op pictures, and you can see how the angle parameters have improved. The image on the left is AS OCT following the phacotrab. The angle has opened up nicely, and anterior chamber has deepened following the removal of the lens. So second patient is a 60-year-old lady who presented with poorly controlled IOP following peripheral iridotomy. You can see that the peripheral iridotomy is not patent and the angle is narrow. Lens fault is moderately high and there's a slight cataract. So in patients like this, when the angle is narrow and when there's significant cataract, best option would be to remove the lens without reopening the iridotomy. So these are the AS OCT images of the same patients pre and post cataract surgery. You can see how the angle has opened up nicely after the cataract surgery. So in addition to the angle assessment in glaucoma, AS OCT can also be used to assess the cornea in detail. But there are limitations. Structures behind the iris cannot be visualized. Hence, diagnosis of posterior mechanisms of angle closure is difficult. And also, there's a cost involved, unlike gonioscopy. So, angle assessment with AS OCT has thus far been mainly focused on measurements of static factors, such as anterior chamber width, the depth. But these static factors offer little information about the dynamic nature of the anterior segment. Recently, there has been increasing interest in assessing dynamic factors such as changes in the iris area and volume to identify eyes that are at high risk of acute primary angle closure. So with that video, I conclude my presentation and thank you for patient listening.
Thank you, Dr. Dilrwani, for your excellent presentation. I think you have taken us through different ways of assessing angles and also the value of anterior segment OCT in different situations when we are angle closure. We will take up questions, I think, after the second talk. I'll request the other panelists and Dr. Mayuri or Dr. Chandrima to have a look at the chat also. So if there's any questions, so please bring them up. We'll go to the second speaker for this evening. And again, it's my proud privilege and pleasure to introduce Professor M. Nazrul Islam. All of you know Nazrul, I think, very well. He really don't need an introduction in India, at least, because we have been interacting with him, on one occasion or the other for many years, and he's a regular speaker in different fora. Professor Islam is professor and chairman of glaucoma faculty at Bangladesh Eye Hospital and Institute in Dhaka. He is the former president of the Bangladesh Glaucoma Society. Professor Islam is current president of the Bangladesh Ophthalmology Society and Cataract and Refractive Surgery. He's a very versatile person, and he has, I think, multiple interests, but mostly on glaucoma and cataracts. And he also runs Bangladesh Eye Care Society. He's a board member of Asia Pacific Glaucoma Society, APGS. And he has contributed many articles, around 70 publications in different national and international journals, and is a regular contributor to a number of conferences. You must have seen him recently in the Asia Pacific Academy of Ophthalmology Congress, and also APGS, and a number of conferences. Actually, we come across and meet him. He has also published many books, 6 books, I think, on primary angle closure glaucoma, as well as many other issues. Professor Islam, it's a great privilege for us to host you for this evening, for this webinar. And again, I extend a very warm and heartiest welcome to you on behalf of Glaucoma Society of India, and look forward to your talk this evening. Thank you very much once again for joining us, and I invite you for your talk.
Thank you, Professor Pandab. It's really a great honor for me to be with you in this evening. And I'd like to thank Glaucoma Society of India and you as president, Dr. Chandrima Paul, secretary, and Dr. Mayuri Khamar as treasurer. And of course, many of our panelists is very known to me, Tony, George, and others. And they're very internationally renowned glaucoma specialists. And of course, very much knowledgeable. So I salute them. Thank you for being here. And of course, my co-speaker, Dr. Dilrwani, very nice to see you here again after some years. And thank you so much. Let me share. I think is it visible?
Yes.
Okay. Thank you very much. So in a few minutes, I'll talk improving my trabeculotomy success rate. Actually, this is completely my own way because every surgeon has a different way of doing trabeculotomy. It is really different surgeon to surgeon. So in last decades, I am practicing and adapting some procedure, and I like to share with you the way. I do not have any financial disclosure. I like to salute this gentleman, John Edward Cairns, who first reported the preliminary report of trabeculectomy in 1968. And till more than 50 years, still with some modification, that is the gold standard of glaucoma surgery. We know in the recent past, there are a lot of glaucoma surgery, especially the mix in the market. But if we consider the efficacy and cost, we know that some good mix like pressure flow in focus, Zen implant is good, doing very good now. But in our area, in the developing country, we cannot afford for our patient. While the trabeculectomy is similar efficacy, It is very cheap and we can afford it. And all of us, we know the slogan of Sir Pengti Khaw, the 10-10-10 trabeculectomy. We are trying to achieve it. And along this 10, I like to add another 10, that is the 10 pounds. Because in India, Bangladesh, our people can do 10 pounds glaucoma surgery in a hospital. So it's very important for us. This is very important. So still, we should not forget trabeculectomy. Like many West surgeons, we must try to do better way. How can be successful? That is our goal. If we look to the very recent study published in the Ophthalmology 2019, the 3 years follow-up of the primary TVT study. And you know, all of you know the conclusion is trap success rate came 72%, even better than the tube, 67%. So it is very encouraging for surgeon like us who is still fond of doing the trabeculectomy. Well, in this slide, I like to tell you that in my opinion, trabeculectomy is not like a phaco or is a day surgery. It's a package of at least 1 month. Before doing the trabeculectomy, we had to work at least 1 or 2 weeks to make the bed for the surgery. And especially after 2 weeks of the surgery, again, you have to follow up very closely to make the successful of the trabeculectomy. So preoperative medication, all of you know that in trabeculectomy, there is some cutting, there is some hemorrhage. So you have to stop the blood thinners. We should keep in mind. And I frequently refer my glaucoma patient who have ocular surface disorder to my oculoplasty colleague to give proper tear substitute and treatment of that. And that actually helps. And I always try to decrease the intraocular pressure at least 1 week before the surgery, even by giving oral acetazolamide, if it is not contraindicated. And definitely, if the pressure is higher than 35, I must use glycerol syrup and at least intravenous mannitol 1 hour before the surgery. So preoperative anti-inflammatory treatment, sometimes I take the help from my uveitic colleague, because whenever I find inflammatory glaucoma in this patient, I refer the patient to uveitic specialist. They frequently I see they give the oral steroids, and oral steroids can be useful in controlling the uveitis and ultimate success of the trabeculectomy. In anesthesia, recently, most of my cases I do under topical anesthesia. And I also do injection mitomycin C. And I dilute the injection mitomycin C with lignocaine. So this way, I get somewhat an anesthetic effect after putting the mitomycin C. And my anesthetic colleague helps me to give some sedative, some anxiolytic drug. So many patients, they can cooperate. And of course, when they cannot, I go for subtenon. But in some non-cooperative patient, definitely you have to do perigalbal. In that case, I give 3 to 4 cc, not more than that. As I use mostly the topical, so patient cooperation is very essential. Patient can look down, and I can use my tooth forceps to expose the surgical area. In case of perivalvular anesthesia, sometimes you have to give the traction suture. I use the corneal traction suture, not the supraorbital suture. I use mostly 6-0 Vicryl, or if not available, 6-0 silk also with this spatulated needle. That I'm mentioning that I use the subtenon MMC with very low dose. I take only 0.1 ml of the 0.3 milligram concentration. Then with 1 ml, I dilute with another 1 ml of Zesocate, that is Xylocaine. And this 0.2 ml, I give subtenon actually, subtenon here in the peripheral part near the fornix. And then I massage with the squint hook or a wet cotton bud like that. So that it should be like this. Even 1 year before, I used to give it pre-operatively 15 minutes before. But last 1 year, I'm using in the same OT table 3-4 minutes before my surgery. During the peritomy, I usually try to make it bilayer. That is, first the dissection in the limbus. And then I use the Moorfield or the Hoskins forceps in most of the time. Then the separate layer. This way I get the tenon very healthy during my closure. And then I go very important far dissection, subconjunctival dissection with closed blade of the scissor. Then I come back. I do in all the sides. Then of course gentle cautery, not much. This again an important part is the half thickness scleral flap. And what I try to do half thickness in open angle glaucoma, but for open angle closure I have a different protocol. So one thing is very important. This thickness is not same here. You can see here the green arrow. I'm going a little bit towards the curvature of the cornea when I'm going towards the limbus. This is very important. If I go straight, I can have premature entry. That is very important. And at the end, I try to show you one thing that my curvature is like this. It should be more on the corneal side and not at the limbus, a little bit away from the limbus. As I mentioned, in angle closure glaucoma, I have a little bit different protocol. I try to make 60 to 70% thicker flap and tighter closure of the scleral flap. Use a releasable tight suture in most of the cases. And I always form the SE with BSS and ER. And also published in this book, where I'm also a co-author. In some cases where I need a target pressure in single digit, 6, 7, 8, 9, in low tension glaucoma or somewhere, I try to make a excision of the deeper scleral flap and make a aqueous lake. So I have found that if we can excise the deeper scleral flap here, this like the penetrating deep sclerectomy, you have to separate this layer, but just excise it. What makes there is a gap here, the aqueous humor just deposits here, make a lake like that, and there is thinning of the scleral bed that helps more percolation and more aqueous outflow. So this is one of the way I do, not frequently, sometimes, and this is very important that I make very small ostium. And the two sides, I make at least 1 millimeter or 1.5 millimeter in the both sides, so that my flow become mostly posterior, not to the side. That is one of the protocol I try. And I try to cut this area, trabecular meshwork. So in the sclera, you know, this is the sclera junction between the blue and white sclera. Just here, it should be the cutting it, not before that. So that is my protocol. Well, in this suturing, I want to show that 3-4 things. If I suture corner to corner and at least 1 millimeter in two sides, it helps 2-3 things. One is it gives very good closure, apposition. Second, it decreases the astigmatism. If you suture here and there, that may produce some irregular astigmatism that is produced. And third is very important is I frequently do the argon laser suture lysis nowadays. So it helps to suture lysis the larger type of suture. And I always vary this 2 knot. Most of the time I give 2 knot, but if the AC is not formed, I give 3 or 4 knots. In some cases where I cannot use the MMC, I definitely do now releasable suture, but not in routine. As I mentioned, I do argon laser suture lysis because it is available now with me. So when the MMC is not available and cannot be given or available, especially in pregnant women, in very thin sclera, I always give the releasable suture. I can give the square flap or triangular flap, doesn't matter. I give sometimes 1, sometimes 2. The conjunctival tenon capsule, yes, I take a little bit more time, and many people will not like it because I do from one corner to another corner. Sometimes I give one corner suture here and another suture here, a position. Then I from one corner to another by 8 of Victrin, I give the horizontal mattress suture. Actually, I learned it from one of my mentor, Professor Robert Rich in New York Eye Infirmary. And after that, I am practicing it. Many people, they do not do it, but I enjoy it. And I found that it is really a watertight suture. I never found any problem in this suture, but it takes some time. You have to do at least 2-3 minutes time for that. And you have to take a good bite in the limbus. Like the Seps trabeculectomy shown by Sir Dr. Pankti Kaur, he has taken the corneal bite. So here also you have to take a little bit thicker corneal bite so that there is no retraction of the conjunctiva and tenons. And finally, only disadvantage here is that you have to too exposed part of the aortovehicle here. And the patient have some kind of foreign recession, 2-3 days, 4 days, then it becomes all right. I always try to see the patency and also the IOP check digitally. So it gives a fluid, you can see very nice ostium and bleb is here, and just touch the cornea, you can understand how much is the pressure. So if it is high, you can remove some fluid. Now, if you talk about the anti-scarring agent, all of us, we use some kind of anti-scarring agent. Ologen, I used to use many 4-5 years before, but now I use very infrequently, especially when I do not use the MMC, or in case of revision of the bleb, or when very thin sclera in that cases, but not regular way, I do not use, because I have seen it doesn't have superior efficacy than the MMC. And another most important is the cost. In our country, it is very expensive, nearly $150, so our patient cannot afford it. If you look to this slide, you see in all the phases of the wound healing, you will find vascular endothelial growth factor here. So definitely, if we can inhibit the vascular endothelial growth factor, theoretically, it should have some anti-scarring effect. And I attended one lecture of Professor Malik Kauk. I was very convinced about his lecture that, yes, it is very useful. And he showed his presentation. Even now in the literature, hundreds of studies you have seen, and some are in favor of anti-VEGF, some are not in favor. But I met Professor Sarpengtikhoy in 2014 in Malaysia in a conference, and I had a talk with him for 10 minutes, and I learned from him how to give the anti-VEGF and what is the effect. And at that time, he used to use it. So from that, I started doing the anti-VEGF Avastin in my glaucoma patient. And similar dose, but he said you can give intravitreal, intracameral, even the subconjunctival. I chose the subconjunctival, subcutaneous after the surgery. Sorry. And I had a small study, prospective study of 100 patients, 50 patients with MMC only, and 50 patients with MMC with anti-VEGF. So I found a quality of success after 1 year follow-up, 76% in the MMC group, while 88% in the MMC plus anti-VEGF group. So I was convinced, and I published also in a journal. I started to do it, but because of the cost, I could not continue in all patients. So I do it sometimes, not in all cases. Now coming after surgery, 2-3 weeks, it is very, very important for day 1 to day 14. I told that it is a package. It is very important for us. And especially important if we find any sign of failing bleb leak, infection, wipeout of vision, suprachoroidal hemorrhage, retinal hemorrhage. So these are very important signs that we should be careful. So let me have a few scenarios. And I think all of us, we face this kind of scenario, either one or two. Scenario 1. If the patient person was very nice, uneventful, but in the next day we find, oh, patient pressure is very good, 6-7, but shallow AC. No leak. What to do? Usually I take the conservative measure. I give doxycycline 100 milligram BD for at least 10 days. I give gentamicin drop 4 times. These are some scarring effect, so it helps. And I decrease the steroid dose, and sometimes I give the bandage contact lens. And most of the time, it actually, within few days, it becomes all right, AC becomes formed. And in some cases, you have to give air or gel in the anterior chamber. Coming to scenario 2, low IOP, shallow AC, and leak. It's not very common, but definitely very, very serious condition, especially if I'm dealing with a case of high myopia, inflammatory glaucoma, post-RD surgery, very important. So in that case, I'll try to go mostly for the surgical repair, leak repair, but primarily 2, 3, 4 days, I can try with bandage contact lens, because I have seen many cases, micro leak, small leak, that actually heals with pressure bandage, doxycycline, gentamicin, less steroid, that we can try. Scenario 3, the malignant glaucoma, especially in the angle closure glaucoma, if I do not do the cataract surgery, it's not uncommon. But fortunately, last many years, we do not find malignant glaucoma too open that we used to find, say, 10 years before, not much. So it is actually, we can do medical treatment with cycloplasics, atropine, but it has been proved by many studies that iridoxyzonil is the very classical treatment for malignant glaucoma. Ultimately, it cures almost 100% of patients. So I take the help of retina surgeon because it is very rare, and I have seen my retina colleague. They can help me in doing very nice. And I have done 2 cases, and 2 cases were very excellent result. So I take the help of my retina colleague here. This is the scenario where we get the flat blade and high IOP. It's not uncommon, but eyes quite deeper AC. What to do? So in most of the cases, I am really fond of doing ocular digital massage. I try to do massage. I give from just direct visualization slit lamp, just in the edge of the blade, you press, you can see the fluid is coming, but always look to the antechamber. It should not be shallow or something like that. You can also give from the inferior lead also, that also helpful. So I do not teach the patient most of the time because they do the mess. But if sometimes I find they really need teaching, then I teach them from the side, just a little pressure like this. That's all. I do not give. And I mentioned that I do argon laser in many of my cases because I tight my suture most of the cases. I try to have my post-op IOP not less than 15. So I make tight suture. So many cases I need to cut the argon laser suture. I do it. So it is the specification that I use in argon laser. Post-op MMC, I do not use much because if there is bleb failure, I have to do, then I do at least about 3-4 weeks because I use MMC in most of the cases. And in that cases, I give it away from the bleb at least 2-3 clock hour away. I wash it very nicely and always observe keenly any AC reaction or not, because that I'm afraid that that post-operative, though it is very diluted MMC, then I'm afraid it can have. Though many people do bleb needling with the MMC, but I don't like much. If the patient needs still treatment after 6 weeks, 7, I of course go for bleb needling. I am really fond of bleb needling because it really helps. But what I do, I use the AC maintainer. Most of the cases, because I have found if you use the AC maintainer, you are really, you can sleep well because there is no hyphema. Any kind of bleeding is not uncommon. It's actually washed out. It becomes washed out. And after doing the subtenon dissection, you go for the sub-flap dissection, and you can even go to the anterior chamber here. You can see I've gone, and quickly you will find the fluid is coming in the subconjunctival space. Yes, it is coming, and you can see this nice ballooning, and you can check the eye pressure digitally. Yes, it has come down. So this way you can do the bleb needling yourself. Though I mentioned that many people use in the literature to find the MMC, but I use the anti-VEGF Avastin in my bleb needling, not the MMC most of the time. So friends, in summary, trabeculectomy, in my opinion, is a package. So you have to be very careful, preoperative preparation, make the surgery in such a way that the patient is going to have successful. And I always try to revolve anesthesia. I give the topical or the subtenon. Antifibrotic agent, you need to do something. Without antifibrotic agent, there is no way of doing trabeculectomy. Now, what kind of, you can give 5-FU. I do not use 5-FU because it's not really available. And I think I'm more comfortable with MMC. So I give more MMC. Definitely, any surgeon can have 5-FU, no problem. And post-op titration after surgery, at least 2-3 weeks, is very important. And I've seen the after surgery, I thought it needs the revision or retrabeculectomy, but with a nice titration, I found the patient bleb remains well, survived, and patient had very good post-op time, even for years. So it is very important, post-op titration. With that, I'd like to thank you again for giving me the opportunity. Thank you so much.
Thank you, Professor Islam. That was a great presentation, and you took us through all the entire gambit of trabeculectomy, which is so important because trabeculectomy still remains the gold standard as far as glaucoma surgery is concerned. In spite of so many new procedures coming in, I think we still depend on trabeculectomy when it comes to controlling intraocular pressure. Thank you so much. So, Dr. Chandrima, over to you if you have any questions from the panel or in the chat room.
Thank you very much, sir. Before we go on to the next session, I'd like to introduce our very eminent panel this evening. So we have with us Dr. Ronnie George, the Director, Glaucoma Services, Shankar Nethralaya, Chennai, and he's also the ex-honorary secretary of the Glaucoma Society of India. A very warm welcome to you. We have Dr. Rita Dhamankar, the head of Glaucoma Department at the Lakshmi Eye Institute, Panvel, Mumbai, and also the principal of Lakshmi School of Optometry. A very warm welcome to you, ma'am. Dr. Thomas George is an ex-associate professor of the CMC Vellore and presently a senior consultant glaucoma services at the Chaitanya Eye Hospital, Trivandrum. A very warm welcome to you, Dr. George. Dr. Sumit Sachdeva, professor at the glaucoma unit of the Regional Institute of Ophthalmology at the PGI MS Rohtak. A very warm welcome to you. Dr. Monica Gupta, consultant at the glaucoma services of the SAM Eye Hospital at Lucknow. A very warm welcome to you. And Dr. Ashok Kumar Nanda, the founder director of the Curve Vision Eye Hospital at Bhubaneswar and treats glaucoma as part of community eye care initiatives. A very warm welcome to you. So with that, we'll move on to the discussion part of the program. And I'd request the expert panel to please go ahead with your questions and initiate the discussion.
I think if just to start off, can I ask Dr. Dilru? I think Dilruwani did it.
Yes, go ahead.
Good overview. You see, the problem is in angle closure glaucoma is that we kind of miss the angle closure part of it, unless you are good in gonioscopy, clinically speaking. What do you see the role of anterior segment OCT? Can that help us in detecting these cases patient early, say in the community level? I mean, in a glaucoma clinic, probably they'll get picked up, because you have someone who is experienced in gonioscopy. But less than that, if you don't have any glaucoma specialist and they're still being seen, these patients, they do visit ophthalmologists or optometrists. Is there a way where OCT, you think, can pitch in?
It's like this now. OCT is an imaging modality which is expensive. So I don't think we can, at a community level, use that as a screening tool. Only because it's not available everywhere, only probably in glaucoma units, anterior segment OCTs are available. So for your question, whether we can use it at a community level as a screening tool, I don't think it's possible. One thing is expenditure and unavailability. But as a tool to screen, now if you're in a glaucoma clinic and if you have doubts, then we can use the anterior segment OCT in discerning the risk factors for glaucoma, angle closure glaucoma. Because as I told you, in certain patients, we are not able to perform gonioscopy. Sometimes we have, though we have time, people don't tend to perform gonioscopy on a regular basis. So I don't think that is a good reason to perform anterior segment OCTs. Ideally speaking, gonioscopy would be the least expensive and where we can get the most accurate information about the angle, because we can see the dynamic nature of the angle directly with our naked eyes. So, but I think it's like CT scans, because now the imaging technologies are evolving greatly. One thing is to identify certain aspects that we can't see with the naked eye. Other thing is to give patient like a more comfortable experience, right? Unlike the gonioscopy. So we can use to assess the risk of glaucoma, not only by just looking at the angle structures, because pupil block is not the only cause of angle closure glaucoma. There are so many reasons, like the reduced anterior chamber depth, then the anterior chamber width, thick iris and the eye curve of the iris, all these factors contribute to the development of angle closure glaucoma. So we can actually, if you do an AS OCT, we can get a lot of information about the entire anterior segment, unlike just doing a gonioscopy and looking at only the angle. So I think in that way, we can utilize AS OCT to get more information about the entire anterior segment.
Thank you, Dr. Dilruani. I think any other panelists? Dr. George, Ronnie, how do you see the role of AS OCT in relation to angle closure?
So Dr. Dilruani makes some important points about the AS OCT, but as she mentioned in her talk, about 72% of the time you cannot, about 28% of the time you cannot actually identify scleral spur. And without identifying scleral spur, you cannot actually look at the rest of the angle parameters. So that itself rules it out as a screening tool, because if you cannot actually identify the structure in 28% of patients, then you can't really use it to screen. So in a glaucoma clinic, the additional information that it probably gives you, the one information that it probably gives you that nothing else does, is the lens vault. On gonioscopy, you would say that's a convex iris configuration or whatever it is. But the one information that it would tell you is a lens vault, and that would tell you the lens component of the closure. The downside of the technology, again, is I think it is still evolving, and we don't have a cutoff for a lens vault above which we will say that this is lens induced or this is not lens induced.
So my question is that does it change your clinical decision making? The ability to study the lens vault, or in 70% at least you can see the CRISPR as well. So how often you think the AS OCT has changed your clinical decision that you have already made or likely to make?
Dr. Pandav, very, very rarely. Having said that, the other concerns that you have is you do get some angle width parameters. With current machines, what you get is not registered. So the next time you take the measurement is not necessarily from that location. The swept source AS OCT has a little bit more promise because you get 360 degrees of the angle. But I have not really had it influence my treatment decisions very often. I'm not sure what the other panelists think.
I think the main advantage of AS OCT is when we can't perform gonioscopy, like when there's corneal pathology, corneal edema, corneal scarring, where we can't really visualize the angle. In that sense, we can probably make use of the AS OCT to image the anterior chamber structures.
Yeah, I think that has more value. But I think if the cornea is scarred or there's a visualization is poor, maybe the AS OCT image will also not be of that great quality. Those, but still it will give you some information here, definitely. Yes.
So would you prefer EPM over an AS OCT?
Sir, I think in the case of arcus senilis, the anterosegment OCT gives a quite good picture of this thing, which is not that easy in a gonioscope. The second point I would like to say is that most of us who are glaucoma specialists, for them probably it's not a very useful tool, but a person who is practicing in general, like me, so we have optometrists who actually dilate the patient comes to the doctor after dilatation. So we have made a standard that any person whom the optometrist feels is a hyperope having +2 or more, before you dilate, compulsory you have to do a anterior evaluation of the angle and you dilate. That's a thing that I have made it compulsory so that we do not land up in any angle closure induced by drug.
I think the problem is, the gonioscopy, when you are assessing the anterior chamber angle, it needs, learning basically. You have to learn gonioscopy, and which is the crux of the matter, because somehow there is there's a gap there. So that's why if we have some tool which can help us, identify those cases, and that's where the OCT. We are talking about the OCT basically. I mean, in today's context, in context of angle closure.
But convincing patients is also much easier.
I guess it's the documentation to convince the patient that is the only advantage that AS OCT really has in an angle closure, because you can do a gonioscopy and you can be convinced that this is an angle closure, but it's difficult to show the patient or tell the patient. Of course, you can draw and show and but if you give them a printout of an AS OCT, it's much easier to explain. That is as far as I think an AS OCT helps. Now, do you, Dilrubani, you've made a wonderful presentation. Do you sincerely think that decision making in angle closure depends on your AS OCT findings? If you have, I understand that there are other factors that affect an angle closure other than just a pupillary block, but does your decision to treat the patient in any way differ? So if you have a plateau iris, for instance, on a gonioscopy, you do see the S wave or the side wave side. So you know that it's not going to work. More often than not, maybe we do an iridectomy and then we find that the angle is not opened out, and then we kind of become wise post doing the iridectomy and say, oh, this is a plateau iris. And then we go back again and then we look more clearly and we probably find the plateau iris. But otherwise, like Ronnie said, if you see a lens vault, would you really go up and do a clear lens extraction to clear out the angle? Because there have been lots of studies which say that even if you do a phacoemulsification, to start with, for the first 6 months, you have a nice depth or a nice angle opening. But after 6 months, that angle opening is no longer as wide. So
yes, for your question, I don't think that treating an angle closure, the decision to treat an angle closure will depend on AS OCT finding. It depends on the gonioscope finding. But as you mentioned, like we, of course, do not entertain doing clear lens extraction, for acute angle closures. There are actually two schools of thought. Some say it's good, but in our hands, of course, we can't really encourage the patient to undergo a cataract surgery without a cataract just for glaucoma. So the circumstances are different in our countries. So I don't think we take a decision to treat depending only on the AS OCT. So we can use AS OCT, for other, now once we do iridectomy, laser iridotomy, if you are not able to sort of get in a proper, opening of the angle, then we can probably do an AS OCT and see whether there are any other factors contributing to that. So other thing that as you correctly pointed out, it is very good as a patient education tool for documentation, because we can easily demonstrate to the patient that we are going to do this is your problem. And after doing a laser peripheral iridotomy, we can, repeat the AS OCT and see how the angle has opened up. Actually, this is an evolving technique. Now the Heidelberg Engineering is coming out with anterior, a swept source OCT for clinical use. So we are actually in the process of, utilizing these techniques to upgrade our medical, decisions. So really, we can't right now, at this moment, we can't say that depending on the resources available, that we can't say that we take decisions solely based on the anterior segment OCT, but maybe with time, if they come up with, anterior segment OCT, which can assess the deep, down depth up to the posterior lens capsule, then yes, we might use, in our normal day-to-day clinical practice.
So like you rightly said, it's an adjuvant to gonioscopy. It cannot replace gonioscopy.
Yes, definitely.
I feel that gonioscopy is an art, basically. It has to be taught to the students, because we being in a regional institute and teaching in hospitals, this art has to be given to the students so that they are well versed with it before going on to the latest technologies that they have. The latest technologies are more of they can give us a quantitative assessment of the angles and the structures there. And later on, they are good for study purposes also, because then we can have a numerical value to add it to a thing, rather than a clinical tool for just deciding that whether we have to go for surgery or not. So I feel that gonioscopy cannot be it cannot be replaced. But yes, OCT is an adjunct that can be used for study, and then can be taught, and of course patient education tool also.
Definitely, Dr. Smith, you have a point, because there's not a replacement for gonioscopy. I mean, that needs to be re-emphasized, and you have rightly done that. But the idea is, at the community level, because still, if you look at the number of glaucoma specialists or number of ophthalmologists available versus the population, we need to have techniques or tests which can pick up the disease even when the expert is not available. So that idea is there anything do you see this technology evolving in that direction? So that was my intention.
At this moment, it is a very expensive technology for the masses. If you say,
but I think with time the prices tend to come down, and as it improves. So, but maybe from medical point of view, we are not still there. I mean, the accuracy is still not there.
The specificity and sensitivity is still not as good to use as a screening tool, at least.
Yeah, and I think if Thomas George is here, then he can maybe talk about his data on the Warneric and the flashlight test to rule out patients who need gonioscopy. And if I'm not mistaken, the negative predictive value was 98.5%.
Thomas, can you enlighten us on that? But that's, again, at the end of the day, that works.
That is a good old study I did when I was in Velo, when Ronnie was also there. Flashlight test and Warneric's, when we use half iris shadow and Warneric's 1 as a cutoff, we can rule out the patients who may not have closure. And that's the 95% that Ronnie said. 95% of patients who have Warneric's better than 1/4 corneal thickness and less than half iris shadow, both together, would not be needing gonioscopy to rule in, for closure. But you still have 30% of the population stuck needing gonioscopy. And I feel gonioscopy is an art. And I think 30 years down the line, I'm still feeling that I'm seeing better each day than what I did the day before. You keep improving on it. And AS OCT, the lens vault is the only thing that I would look for. And that would justify us a little more when we think of an earlier cataract surgery.
And in a rare disease, pigment dispersion.
Monica, you want to say something?
Yeah, ma'am. We can use anterior segment OCT for a rare case like pigment dispersion syndrome, patient counseling, to show them that there is a rubbing of posterior surface of iris with the lens, and this pigment dispersion blocks the trabecular meshwork and can cause increase in intraocular pressure. I'm following up so many cases of pigment dispersion syndrome, young patients, and they came with advanced glaucoma. So first, in these cases, it is difficult to counsel them for peripheral idotomy or for surgery. So I think AS OCT can help to make them realize the pathology.
Ronnie, does it help you? Like you did mention about the vault, and if you have a cataract, so do you use it for deciding cataract surgery in angle closure glaucoma?
I don't, but I asked Tinon, who published the paper on. I asked him, what is the cutoff that you use? He said, I don't know. So nobody knows the cutoff of the lens vault beyond which you would use it to justify a lens extraction. So really speaking, if you want to convince yourself or you want to tell the patient that this is the reason why you want to do it, perhaps. Or if you want to see whether that is getting worse, yes. But right now we don't have a cutoff below which we would say this is safe or this is not.
So I think it comes down that your clinical judgment still is, is supreme, and other things most of the time you are using just to justify what you are going to do. The decision you're going to take clinically, you are looking for some more justification for that. Then you depend on these technologies, and they really don't alter your, the basic, the impression or the decision making that you have made. I think technology is still evolving, and maybe with time we'll have some more information.
And using AS OCT, sir, to see the dynamic changes, we have stopped doing the dilatation test. So dark and light examination is done when we are in doubt. That is one use. More use I do with the AS OCT, and secondly, I do study my blebs. And I think that the pressure has started going up, and otherwise good looking bleb. But when you do the AS OCT, sometimes you can see the fibrosis coming up. So then you can manipulate the lab and change the post-op.
Okay, so
these are another two uses can be used. If you have technology, why not to use it?
No, definitely. But I think the question is because, as already mentioned, technology comes at a price, at a cost, and which ultimately the patient has to pay. So, but I think your suggestion that you can study these blebs, and before the IOP goes up, if you see fibrous tissue coming in, perhaps you can intervene early. So you have a point, definitely a point there. So that brings us to glaucoma surgery. I think Dr. Nazrul, any question to Dr. Nazrul regarding the surgery? Dr. Nazrul, I just wanted to ask you, you said most of your surgery you're doing under topical anesthesia, surface anesthesia.
Yeah.
Do you use intracameral anesthesia, while before you're doing iridectomy in these patients, like intracameral or something?
Very, very nice question, because actually I used to do it. But recently, in the pandemic time, I cannot bring it from India. So I don't have now in my hospital, I don't use. But whenever I'm using the MMC, I'm using a little bit lignocaine also. So that also helps. And many cases I am to supplement with the subtenon. I also give 1 or 2 cc subtenon just in the periphery, so it also helps. And in 99% cases, the patient doesn't have any pain for that. And another important part is my anesthetist. The anesthetist, they do very good thing. They give some drugs, not only a sedative, anxiolytic drug. That also helps the patient to be quiet. That I get that help from my hospital, from my anesthetist friends.
So, Dr. Nazrul, one of the things with sedation is that the patient goes to sleep.
Yeah.
And sometimes they snooze.
I understand, but it's not that sedation. They make light sedation somewhere that patient forgets and do not feel much pain. It's kind of anxiolytic. They take dormicum, I think, like a little bit dormicum. And another drug they give also that makes up anxiolytic. Not that much sedative that patient becomes really sleep. In snoring, it's not that, but a little bit patient becomes drowsy and doesn't feel like a pain. This kind of thing they do, and that helps me for doing the topical or subtenon anesthesia. Because peribulbar, I give maybe 1 or 2 patients in 10 patients, not much. Whenever I feel the patient during biometry or during examination was really non-cooperative, during gonioscopy, I found the patient is not cooperative. I understand this patient will not allow me to do topical surgery. So definitely I mark them needs PBA, peribulbar anesthesia. So this way I select my patient.
I think 2 steps, what I have noticed is that the 2 steps where patient become a little uncomfortable, under topical anesthesia. I also inject, very,
intracameral
in the spirophonics. They become uncomfortable. They experience some pain when you're doing cautery and in that area, and also when you're doing iridectomy.
Yes.
These are the 2 places where patients become a little uncomfortable. Rest of the procedure can be done very easily. It's not
Dr. Pandab, I think you have pointed very nicely. Whenever I try to do gentle cautery, if a patient feels pain, I straight away go to subtenon. But if I understand the patient is not feeling any pain, I continue. That is my strategy, that if the patient feels a little bit pain, I'll go for subtenon supplement. And that is the first area where the patient feels pain.
Dr. Nazrul, I'd like to ask you about the anti-VEGF, which you said that you use instead of mitomycin C. So no wonder, definitely mitomycin C is also an off-label drug, but then anti-VEGF, Avastin especially, we had a lot of hue and cry, and the company went out on record saying that it is not recommended to be used in eye surgery. So what is the scenario like in your country, and what are your results with anti-VEGF as compared to MMC in trabeculectomy?
Well, thank you, Dr. Chandima. Actually, in Bangladesh, it's not like India. The scenario is a little different. Here, the off-label, the MMC and anti-VEGF were using, especially by the retina surgeon. And from the Bangladesh Retina Association, they have told us you can use it from the association as the off-label drug, the Avastin, that we can use. And anti-VEGF means not Lucentis, rather we use Avastin only, the bevacizumab, that molecule, not the expensive one. and visit. And I use in the glaucoma surgery not only anti-VEGF, I use the MMC also. And I have shown my study in 2015-16, I done 100 cases. One group 50 cases only with MMC, the subtenon MMC, and another group MMC along with the anti-VEGF post-operatively. So these two groups. So in this two group, I found the bleb quality and success was better when in the group of Avastin group. That is the MMC plus Avastin group. So I never used only Avastin in any case. Only thing is I used along with the MMC, just like that.
So
and when I do the
bleb
needling, I do not use MMC. I rather use the anti-VEGF. That is my protocol.
And in what ratio do you use the Avastin and MMC when you're using them both combined?
No, I do not mix each other.
Okay.
I do not mix each other because MMC I am giving pre-operatively. When I used to MMC, the study that I used to give 15 minutes before. MMC subtenon, I used to give pre-operative room. Then after one surgery or 15 minutes, then I bring the patient to the operating room and I used to do the surgery. And after surgery, in my study, I given the subconjunctival anti-VEGF. So there's total two procedures. One is before surgery, another is after surgery. So there is no way of mixing each other. Now, actually, why I'm not waiting for 10-15 minutes, because recently you can see in different conference, people are using the on-table MMC subtenon, because it is saying that the MMC absorbs very quickly in the tissue. So it has been seen after 3-4 minutes that the MMC is not there. So you do not need to wait for 10-15 minutes. And that is the reason I am using now at 3-4 minutes. After that, I am doing the surgery. In case of combined, I am doing the combined, I give the subtenon MMC first. I wash it out. I do my cataract surgery, phaco surgery completely separately, temporally. I close with a slip knot of the tenon nylon in my main Swiss. Then I come superiorly for my trap. So that is my way. I do not, many people do the flap first, go to their phaco surgery, then again come to flap. But many years I am doing totally separately. First I complete my phaco and get a little bit viscoelastic in the chamber, make it a little bit harder. Then I give also a suture slip knot. Then I go for trabeculectomy. I finish it. Then again I wash it into chamber. I suture the main wound. And that way I do my combined also. So in case of combined, still I give the MMC before starting my surgery. So definitely after 10-15 minutes, I do the trabeculectomy. So that by this time I do the cataract surgery. But for the only trabeculectomy, I do not wait much, maybe 3-4 minutes in the table.
Okay. So there's a question from the audience.
Combined also you do under topical?
Many combined, many cases I do topical. I counsel the patient that if you can really help me, cooperate with me, because actually doing topical trabeculectomy and combined is not makes difference, because phaco surgery has no problem for combined topical. But if patient cooperate trabeculectomy alone, then he or she can also cooperate with combined. So many cases I do. It's not that in combined I'll do peripheral, but if I feel that my patient can cooperate, because units of cooperation, looking down, patient needs to do, and also many patients are they cannot even tolerate a little pain. They are not good patient for the topical. So in that patient, you have to go peripheral. But if the patient can tolerate, even the combined, I go for topical and subtenon. Topical means not only topical, subtenon combined, like that.
So, Professor Nasrul, just one question.
Yes,
now, post-operatively, when you do the bleb needling, you use Avastin or bevacizumab in your case. So, do you repeat it several times, and how often do you repeat it if you need to repeat it?
No. I give only one time during bleb needling. I go with my needle. So I go subconjunctival, subtenons, and subplap with the same needle, same Avastin needle, so that it also goes in the around area. Some Avastin may go to the interchamber also. I'm not afraid of because Avastin has no deleterious effect. And if I do again the bleb needling, say after 3 months, then again I use the anti-VEGF. But not like MMC, we give, say, every month post-operatively, if my bleb is not flat, then in that cases, you can use only MMC. But in my cases, anti-VEGF, I don't give only anti-VEGF. Just in case of bleb needling, I use the anti-VEGF.
So have you had any experience with 5FU and Avastin separately?
No, I didn't have any experience. I didn't have any study like that.
So now in our country, though Avastin is off-label and not FDA approved to be used intraocularly, we have got actually that included in our local drug formulary. So we actually can use Avastin intraocularly or for any ocular use. So India, do you have anything like that for your country? No. So though it's FDA not approved, but in our country we can still use because it's approved by the local health authority.
Yeah, in India also, ma'am. In India also it is not approved, but we do take consent of the patient, explaining that this is off-label indication, and the patient gives a written consent, and then we use.
Do you use Avastin, Dr. Nanda? Do you use Avastin still?
Yes.
Okay, because Avastin, the company went on record saying that it's only for colorectal CA and not meant for ophthalmic use. Yeah,
but we still take a consent and do use that. My question to Professor Nasrul is that you said you use only anti-VEGFs for bleb needling. Many studies have published saying that if you are using only anti-VEGF in a combination to trap, usually the bleb effect stays for a few months. And again, subsequently, the bleb becomes fibrotic. So it is always advisable to add it with mitomycin C. Now, if you are doing a needling and only using, would it not be the same effect? I mean, the effect lasting for a few months, and again, it goes into fibrosis.
I agree because MMC has very strong antifibrotic action comparative to anti-VEGF Avastin. I agree. But somehow I didn't use much along with the bleb needling because I'm afraid that if the MMC goes intracamerally, it can have some deleterious effects, some acid reaction, all that. So actually, in my practice, I don't do. But definitely, many surgeons, and maybe you also use the MMC during your bleb needling.
You are using mitomycin C 15 minutes before the trabeculectomy. So if you are not afraid of that, I think you should not be afraid of this also. You can give
that I'm giving before opening the globe, before opening any incision, that I'm doing. And after 5 minutes, 10 minutes, it is already absorbed. So I'm doing the bleb needling, then my eye is open. So in that case, it is not same using in the trabeculectomy before using and during the bleb needling. With bleb needling, your ostium is open. So in that time, it can go very easily to the antechamber. So this is my thought. Definitely people can do it. And I told that glaucoma surgery is actually, I think here many of us will not be same from one to each other. They'll be different a little bit from one step to another. Thank you.
So for how long have you been using this preoperative mitomycin now? Have you had any bad experience with regard to cystic blebs and bleb leaks and, on a long-term basis?
I'm using for last 5 years. 5 years. When I started, actually, I was speaking for maybe for 5 years. Actually, one of my patient is very VIP patient. He's a secretary. And I had a complication with the sponges, FMC sponges, and very little fiber. Then after 15 days, I found there's some reaction. There is some conjunctival reaction. What happened? So it has not been cured. Then I opened it. I found very small fragment. And then I realized that it is not a good thing. It will have a one time in lifetime. That will be a very bad time for you. So from then I realized that people are using subtenon MMC. Let me try. Then I started searching the literature, and different literature showed the positive result. And now, I think after 5 years, I think many surgeons, maybe 50% glaucoma surgeons are using the subtenon MMC, and 50% are using the sponges. So I am using for the last 5 years.
Professor Nazrul, I just want your clarification on this. You said that you use 0.3 milligram, which you dilute 0.1 ml with 0.9 ml of lignocaine. Is that correct?
Not that. Let me clarify. I take 7 ml ASS or distilled water in 2 milligram vial MMC.
Okay.
That produces about 0.3 milligram concentration.
Yes.
From there, I take only 0.1 ml.
Yes.
That contains only 0.03 milligram.
Yes.
That is my amount of MMC in my patient. And that 0.03 milligram in 0.1 ml of the MMC. And I dilute with 0.1 ml of the lignocaine. So this 0.2 ml contains that 0.03 milligram of MMC.
Yeah,
very little amount.
Yes, I just wanted to clarify that to all the viewers that we are not giving the full dose of mitomycin that we give.
No. We're diluting it.
So on that note, I'll just take one question from the audience about needling and MMC. So that's what precaution do you need to take for bleb needling with MMC and the ideal concentration and quantity of MMC to be used in needling? So Dr. Ronnie, would you take that question?
Okay.
Well, there's a whole range of concentrations which have been described, but I think the most commonly used concentration is 0.01. So you're giving about 5% of the concentration that you would normally give for a sponge.
Any precaution to be taken?
Yeah, give it away from the bleb. Try and make sure that it doesn't go into the anterior chamber. And if you suspect that you're going to be doing very aggressive needling and you're opening the anterior chamber, then you have to be very careful because mitomycin in the eye is a recipe for disaster.
I think most of us, my impression is that most of us still use 5-fluorouracil for needling. So
it's easily available and it's cheaper than mitomycin.
And safer as well.
Yes.
You do get a lot of corneal erosions or SPKs post 5FU. So
yes,
I think that used to be when you were using it, more frequently. I think if you go back to 80s and 90s when these anti-metabolites that came into picture in glaucoma surgery, I think 5-fluorouracil was the first one to be used. And at that time, we were giving multiple injection actually, for first 14 days, you will probably give, 7, 8, sometimes 10 injections, and that would lead to a lot of corneal problems and even, gross epithelial defects. But I think subsequently the practice has changed. Now, most of us use like as and when required basis. So, and I don't think, I usually don't exceed for more than, 3 injections over a period of, 7 to 10 days, whenever I have to use it. I don't use for all patients, but whenever required. I think my upper limit is about 3 injections, rarely 4th one.
So one other question to Professor Nasrul. Now, when you perform the argon laser suture disease, following MMC traps, how do you time it? Because sometimes when we do argon suture disease, we end up with, excessive flow and flat anterior chamber. So when do you exactly do? How do you time it? Like?
Dr. Dillon, thank you. Actually, if we need the bleb suture cutting, we try first with the ocular digital massage. And if it does not work, then I try, but not before 7 days, because I use MMC almost in all my cases. So before 7 days, it can have very shallow anterior chamber, very high, flow will be high. So it is really dangerous. So I wait at least for 7 days. Mostly it is better to do after 2 weeks, if I do. But again, before 1 month. Because after 1 month, I've seen people can cut the suture, but usually even by digital massage, the fluid cut doesn't come. So my protocol is usually 2 weeks to 4 weeks. That time is better time for me to do the argon laser suture lysis. But before that, I try with digital ocular massage for the flat bleb. And most of the time, if you do very correctly with the direct vision with the slit lamp, you will be successful to do the massage to raise your bleb. Most of the time, you'll be able to do that.
Why would you not do the releasable suture instead of doing the argon suture lysis? Because you did show us a place where you did do a releasable suture. So don't you think it's very simple to just finish your surgery with a releasable suture and not depend on an argon again.
Yes, yes. I don't.
Madam, thank you very much for the good question, because actually in Bangladesh, India, we do it. Even myself used to do releasable suture in all my cases, maybe up to 5-6 years before. But now I have stopped because I have the very good facility of doing the argon laser suture lysis. And I don't have the extra time to that releasable suture. I don't do much. This is my practice. And I do very occasionally, not always. Simply, I do 2 suture in the 2 corners in maybe 90% of my cases. And if I find that there is some leaking, AC is not well formed, I do 2 suture in the 2 arm. That is my practice. And I cut the 2 corner whenever I need it very easily with the laser. So I feel comfortable with that. I can make very tight suture. So as facilities here with us, so we enjoy it. But definitely no harm of giving the releasable suture, no harm.
We also perform, we also do tight suturing and then use argon laser suture lasers after surgery. And that's easier way of doing it if you have the facility. Yes. One other question, just on table, do you put atropine for all your patients following surgery? Or you
Yes. All glaucoma surgery and combined, I give atropine or homatropine on the table, and I continue it for at least 2 weeks. Especially, it is important for the angle closure glaucoma cases. I never try angle closure glaucoma cases without atropine at least for 2-3 weeks. I'm afraid these are the patients only for glaucoma, only for trabeculectomy, that have the potential to have the malignant glaucoma. So actually, if we use routinely the atropine, I find very, very rarely the malignant glaucoma cases. But with the open angle glaucoma, if the patient is fine, after 1 week, I stop the homatropine.
Okay,
and one thing, I have done some cases in open angle glaucoma, high myopic cases without iridotomy. And maybe around 10-11 cases I have done, and they're doing good. I don't know experience with panels or not, but many people are doing in the West. So encouraging with that, I have done some cases, the high myopic cases, and I have not done the iridectomy, and they're not doing bad. Any experience of panel on that?
I know of Dr. Paul Palmberg in Bascom Palmer, who doesn't do an iridectomy post his all traps. He believes that there is no need to do an iridectomy, and his cases are doing fairly well.
Actually, our eyes are not same than the West blue eyes, brown eyes. So our eyes, I think, needs iridectomy. And especially in the angle closure glaucoma, without iridectomy, I think it's impossible to manage.
I don't believe in that non-iridectomy principle. I think we are creating a nice passage. We are giving.
Dr. Rani does many surgery. Do you have any experience of not doing any iridectomy?
I can count on the fingers of one hand the number of times I've not done an iridectomy in a trabeculectomy. There's everybody else I do an iridectomy. I think it's
I think in the high myopic cases, AC is so deep that is a rare possibility that it will come to occlusive ostium. So in that ground, possibly it can be done. I didn't make any study on that, but just to know how it behaved my patient. So I found it's not bad, working fine. And the patient eye looks very nice. In the trabeculectomy eye, usually there is a iridectomy. Sometimes it becomes bigger, sometimes broader iridectomy. But without iridectomy, the eye looks very nice.
I think what we are concerned is basically the pupil, the shallowing of the AC in the post-operative period, the pupil block and the aqueous misdirection. So iridectomy does give you some safety there. So
definitely.
So if AC remains deep, then probably you can get away with most of these cases, but it's not unusual to have shallow AC in the post-operative period, and that's where I think iridectomy probably saves you.
Of course.
Many times, I would say.
And floppy iris, of course, is also a concern. If you do not do a PI.
Definitely, PI is essential. But I am asking our panel have any experience on that, because in the Western surgeon, many, as Dr. Rita told, many surgeons, they do not do iridectomy. But in our part, the people we need to do. Because without doing the trabeculectomy will not be possible successful.
We have many more cases of angle closure than the Western people.
Yes,
that's why we tend to have, we have it's in our habit that we do in every case it is required.
We also
but what do you think about the very deep AC high myopic cases? What is your thought?
Well, it has been a practice to do a PI in all cases.
I know. But theoretically, we would consider this patient a very rare possibility to occlude the ostium by the iris. So you can try.
Again, the issue would be if in the early postoperative period you get any shallow AC. So
yes,
myopia doesn't actually protect you there.
But I have had like 2 patients with high myopia, but going into angle closure. So we have to always consider that possibility also, though they are high myopic, still the angle can be crowded. So
yeah, that's true.
I am a refractive surgeon. I know that in at least 25% of high myopia, the angles are not very, very deep. The antechamber volume is less.
In many cases, yes.
Does Chandraman, do you have any questions from the...
So, no, we've just crossed the finish line. Right. So I think if we don't have any more questions, we can actually end here. And I'd like to thank Dr. Dilruwani for the wonderful talk and for being with us here this evening. And Dr. Nazrul, who I've known for a very long time, and we've been at various conferences and been over to Bangladesh at his very well-organized conferences. And thank you very much for being here with us this evening, Dr. Nazrul. And both of you, we look forward to your physical visit to the GSI sometime in GSI conference, annual conference, sometime in the future, maybe even this year if we are all right. It's on the 17th, 18th, and 19th of December at Guwahati. That's quite close to both Sri Lanka and Bangladesh. Yes. So I extend a very warm welcome to both of you for the conference. And thank you very much once again.
Thank you.
And thank you very much this evening for being here with us. Thank you for your inputs and the wonderful discussion.
From the core of my heart, thank you too. And really we thoroughly enjoyed the whole webinar. And I also learned many things from this. Thank you very much.
Yes, thank you very much for the entire group from India Glaucoma Society for inviting me and giving this opportunity. Thank you very much.
Thank you
everyone.
Very much.
Everyone.
Thank you.
And thank you. Thank you very much.
Have a nice weekend.
I'd like to see you also in Bangladesh physically.
Yes, I look forward to that.
Thank you. All of you. All of you.
Thank you.
Thank you.
Thank you.
Okay. Good night. Have a nice
Good night.
Good night. Good night.